Hello, everyone. I'm Robert Dempsey, and on behalf of the Department of Neurological Surgery, I want to give our update on the COVID-19 situation as we stand now in the middle of December. As you know, this disease has been known for 1 year now. It is called COVID-19 because it was discovered in 2019, and we are soon to be into 2021. So this is a significant spell. It is similar to the 1918-1919 pandemic, which I often compare it to. And the duration of that, I'm happy to say that one ended in March. So let's hope this will be similar. But I think it's going to take some extra help. So what we're talking about today is the surges of this disease, its side effects, and vaccinations, because this is really the issue of the day. It's one of the two bright spots in the story of the pandemic, the other being that our particular surge in Wisconsin has been decreasing this last week. And so that's kind of important to know. So the first thing we need to understand is that we have been in this massive pandemic and its effects have been worldwide. 75 million people infected worldwide. And as you understand, worldwide, we may be twice as many. In the United States, we may be missing 30, 40% of the people. But worldwide, we're easily missing another equal amount. The US deaths have well surpassed 310,000 now, and that's amazing. We have 3,500 people per day dying in this country, and that's more than at Pearl Harbor. That's more than at 9/11. That's more than major battles of the Civil War. Those are in history for generations. They define your generation. And during this pandemic, that's happened every day. So the people who have minimized it, this is a terrible injustice because this is severe. The second thing that's severe about it is the complications that are not respiratory. We're seeing an unusual increase in strokes, including strokes in young people and children, which cannot be explained by happenstance. This is likely to be one of the many reasons I do not want you to get COVID-19. And the people that think that the approach is to get herd immunity, if they're honest, like the people in Sweden are, they're saying they made a tragic mistake. If they're dishonest, then they're just working for their own interests. But the cost of being infected, are concerning that a small number develop renal, cardiac, and neurologic symptomatology, which can be seen as vessels, stroke down the line. This is something we're seeing in the ICU now, and it concerns me. It's why I don't want you to get this disease. So this brings the point, what's going on in Wisconsin? While the United States still leads the world, partially because of our inadequate response to common sense, which is mask, wash hands, and separate. Separate so that the virus cannot jump from person to person. That's pretty simple. Where it's been done well, it has been manageable. Where it's not, it's been terrible. And the hotspots in the United States continue, but they move. So for reasons that I don't understand, no one does, the real hotspots last about 3 to 4 months. One can come back. But Wisconsin right now clearly is on the downslope of being one of the great hotspots of the world. In October, when they did studies of what were the 25 worst cities in the United States for COVID, 10 of them were in Wisconsin. And now only one, Beaver Dam, remains in that top 25. We're seeing a decrease of between 10 and 30% in cases, a decrease in hospitalizations of about 15%, but still an increase in deaths. And our hope is that as cases go down 2 to 3 weeks later, hospitalizations go down, and 2 to 3 weeks later, deaths will go down. This is kind of our window of opportunity, but if we want to eradicate that in this country, we need to do more because we have not found that resolve to protect each other as much as I hope you are protecting yourself and your family by isolating, masking, washing your hands. So that brings up vaccinations. And this is obviously the big news of the day. And as I stated before, there are about 36 vaccinations in trial for this. And as I've stated before, vaccinations take many types. The classic one would be you're inoculated with a disease which is similar to the really fatal disease. Cowpox is like smallpox, but you don't die of cowpox. So they gave everybody that. And smallpox was decreased and actually eventually eliminated. It's amazing. I still have the scar from my smallpox vaccination. Most of the people I'm talking about have no idea what I'm talking about because it's been gone. That's very tough to do. And most viruses, we don't eliminate them. We simply decrease them by inoculating enough people so they don't get it, so the virus can't jump to them and it loses hosts. There are pockets and it comes back, you re-inoculate. Now, these vaccines take on many forms, but simplistically, we rarely give you another virus. We usually give you the killer virus, but kill it or deactivate it so that you get a very mild case. It never becomes severe, and then you're immune to the fatal form of the disease. Or we take a virus which is not supposed to harm you, maybe from a chimpanzee or something like that, and put particles of the severe virus in it so that that mild, you don't even notice it, infection with the simple virus carries the antibody, the antigen, which your body recognizes when you are affected by the severe virus. Lots of those out there. And then the two that were developed fastest because of the new technology, but at great expense, where they give you a piece of genetic material and you make a protein which is specific to that virus. And when that virus comes to you, you recognize that protein and you stop the virus. So of those are the first two that came through because they could be developed faster, but more expensively. That's Pfizer and Moderna. Trailing right behind it is the AstraZeneca. We'll talk about those three. The other 33 are out there. They may become the standard in the future, but they're not the discussion of today. All right, hopefully you can see this screen. These slides were made thinking that I'd be giving this talk a little earlier, but we had the resident candidates, so some of the dates are out, but it makes sense. Right now, the two vaccines that have been brought through the approval process to where they could be available are the Pfizer and very soon the Moderna. They are both very similar. They both have that new technology, so they don't react to people who have had others infections or other allergies by the same mechanism, but they seem to be effective. Both have had trials in about 30,000 people, which for a disease that affects 75 million, you can understand that's a small trial. Both have shown that they are efficacious, meaning that when you think of all the ways they give a vaccine, some of them don't even cause you to develop a reaction, an antibody. So those are tossed. Others, you might find that it doesn't last. We don't know that. And others, you get an antibody, but it's not enough to stop the disease. Both of these have shown in these 30,000 people that they do not get infected at all as commonly as the control group, 20 times less than the control group if you got the injection. And if you did be one of those 1 in 20 that got some coronavirus infection, it was mild. So that's very efficacious. It seems to work, at least initially. We do not know if this lasts for a lifetime, like some vaccinations, or if you'll need boosters. All that needs to be determined. Safety is the second thing we look at. And all we have is we know it's pretty darn safe for 2 to 3 months. We don't know long term. As I said before, a lot of the safety trials are going to be in the first people to get the shots. This is one of the reasons why in the United States, the first shots are given to the healthcare providers. They've got eyes wide open. If you take the shot, you know you're part of the safety trial. In other countries, such as Great Britain, they are given to the confined populations, such as the nursing homes. Again, this was raised in our last discussion about the need to have a careful discussion of the ethics of who gets it, both because people want it, because I believe this will protect you at least for the next several months from this infection, but also because you are not sure about its safety. So we have had approval for the first vaccine, Pfizer, and it was unfortunately not one of the ones that the US government bet on highly. The US government bet highly on Pfizer, Moderna, and AstraZeneca. They bought 3 times more doses of AstraZeneca, and it hasn't cleared approval yet. But they bought 100 million of the first, the Pfizer, initially the same amount of Moderna, but were approved to double that. So if that's approved, a lot more vaccine will be available within the next 10 days. Pfizer got approval first, they shipped. Now they are the one that has to be kept at -80, very cold. So not everybody has freezers like that, but the University of Wisconsin does. We're also very close to one of Pfizer's shipping hubs. So we were one of the hubs to get the first doses. We received 3,900 doses on Monday, and we began to give them out immediately. And so this is this first phase. And this is primarily the healthcare providers. That's been the US decision. Frontline healthcare providers, they would both be protected and they would also be the safety. Phase 2, when it's more available, we have more understanding of the risks and benefits. That's going to be probably February, March, April. There'd be more in the general public. And so how do we do that? Well, this is what's going on. Pfizer and Moderna report their efficacy, which is exciting. There isn't a lot on safety. FDA approves the first and will, I predict this week, approve the second. People will start to ship. They've made it. They've bought it. They just need to have approval to give it and to ship it. Moderna will be more widely shipped because it needs only to be frozen, but not deep frozen. And here at the UW, what are we going to do with those 3,900 doses? And we are promised there will be more doses behind. So the first thing is both of these 2 vaccines require 2 doses approximately 3 weeks apart, 2 to 4 weeks apart. They have promised anybody gets a first dose, will get a second dose. We therefore will give out all 3,900. That, of course, will not cover all 13,000 of our healthcare providers. So they are divided up. So this is what we call phase 1, and that's just the healthcare providers. Again, this was a governmental decision who in the United States gets it first. In other countries, it may be politicians. In some countries, it's elderly people in nursing homes or prisons or groups like that. So in this first group called phase 1A, those are all the people that work in healthcare and have contact with patients. Those groups at UW are divided into four. And that has to do with really how we predict your risk is of getting this. The first group, for example, would be characterized by nurses who are doing pulmonary care in the COVID unit on people with COVID. That's very high risk, their first group. The second group would be doctors and nurses that have contact with COVID patients regularly, but not continuously. That first group is about 2,000 people. The second group is about 4,000 people. The third group would be doctors and nurses that have a lot of contact with patients, but they're not likely to be COVID. They're as likely as anyone in the street. And the fourth group would be someone who has contact with patients, but not close. For example, the receptionist in the clinic. They have contact with patients, but we're able to keep it fairly separate. That will exhaust our first group of dosing for certain. We do think, however, we will get through this group really within about a month to a month and a half, counting on more doses of vaccine to be coming. The important point of that is, if this goes well in the health workers, we will be, I would predict, in late January, having enough dosing to start talking about the public. The ethicists are still trying to decide, is it, as I suggested, going to go to the nursing home, the highest risk people that are going to die if they get this disease, et cetera, et cetera. Different states seem to be highlighting, let's say, meatpacking people or something to be important for the food supply because they have had a lot of disease. They work closely together. Others doing other things like their favorite industry. This will be where politics and medicine come together. My prediction is, though, that we're going to see the healthcare providers that want this to get it in the next month. So which group you're in may not be that important at all. The groups were arbitrary. We just have to deal with that and stay healthy until you have the opportunity to be inoculated. The important thing to know as you go through this is that no one has to. Within the groups, they're trying to weigh the groups by your age, because if you see the risk of severe disease is exponentially increased as you age, and also by socioeconomic factors, because that also has been affiliated. The socioeconomic factor we weigh to a lesser degree because we don't measure it very well. But nevertheless, they're attempting to do that. The other thing that's important is it's important to know that we're trying to do this on your intensity of duration to COVID. So vice presidents and executives, administrators, they don't fall in that group. They don't have direct patient care. At least in this place, they're not getting it first in line. I know that there are exceptions nationally where major leaders are getting the vaccination to show their faith in it. But here, this is going to be who's at greatest risk. So we have indeed gotten our first batch, as this says, with expected. We have notified people what tier they're in if they have direct patient care. And we hope to get through this and get to people without direct patient, including our families, as soon as possible. Now, thus far, we know that the Pfizer vaccine has side effects, just like many shots do. Local pain, low-grade fever, feel crummy for 2 days. It is therefore important not to get vaccinated along with all your coworkers. Because if we vaccinate every nurse in one nursing unit on the same day, this would be foolish. So we're spreading that out again, because if they have minor side effects, we want to know about that. We have not seen major side effects, but they do exist. A case in Alaska, 2 cases in England. This may be the normal distribution or may not be. This is what we'll find out. So we're recommending that the schedule be sort of spread out if you work together. So what does all this mean? Well, it's some very important things here. Nobody has to get vaccinated. I do recommend it. I think the consequences of getting this disease are worse than people thought. And I know that the fatal consequences are happening in people we care about. But I worry about the heart, kidney, and brain function of people that have the subclinical course. That's my concern. It is hopeful that the vaccination, as it does with other diseases, will protect you from that. It certainly does for the first 3 months. That's all we know so far. It remains to be seen whether this will be lifelong or not. It's conceivable that this virus will be diminished enough by vaccination that it will not rise again. I doubt that. It has shown repeated small mutations. The 1919 virus mutated itself out of existence. This one's, its mutations seem to make it easier to catch, which is not a good thing. And it is much more infectious, easier to catch it than it was 8 months ago. So for these reasons, I do recommend, and I think the attitude that some of my partners had, which was best, is when they give me a chance to get it, I'll get it. And we're going to have to trust that we're doing our best to try to inoculate the people at greatest risk first, second, third, and fourth. I won't rest till I know that the people most vulnerable, the elderly, the people who are institutionalized, have opportunity for this. And I won't rest until we find which of these vaccinations is the best and the safest. It's going to take some time. So it is the best of times, it is the worst of times. It is a Dickens novel. However, we have gotten through this by being together. And it's the holiday season. I want to wish everybody the very best of that season, whether it be a religious holiday for you, if so, the very best. If not, please embrace each other, family, socially distanced, of course. And thank you, because we've been through a very hard stretch. We can see a light at the end of the tunnel by working together, and we must stay safe during that time. So thanks once again.